Good evening, everyone. This is the third of our international webinar series on glaucoma. And today is on the surgical management, the challenges of surgical management of glaucoma. And we have Dr. Arvind Nilkanthan, who has done residency from Mumbai, and he has done fellowship from SN, and then he had gone to US. So he will talk about the future of glaucoma management. Then we have our own George Puthuran from Arvind. And we have eminent panelists all across Pan India. And I will introduce everyone in short time. Before that, I will request the Jignesh Taswala sir, our president, to welcome before we start the seminar. Dr. Taswala sir, please.
Yeah, thanks a lot, Dr. Rajul, for including this under the aegis of Maharashtra Ophthalmological Society. I, as the Honorary President of Maharashtra Ophthalmological Society, welcome all the experts and the faculty and the panelists who have been part of this, who will be part of this grand webinar, which has been painstakingly done by Dr. Rajul and Dr. Shefali. So I wish you all the best and the best of the webinar series on glaucoma, which is going on during this glaucoma month. So best of luck, all of you. Yeah, Rajul, over to you.
Thank you. Thank you, sir.
Thank you, sir. So I will just introduce all the speaker, and then we will ask Dr. Arvind to start his talk. Dr. Arvind has some problems, so he may not able to join immediately, but he has already sent his presentation. So we have Dr. Arvind Nilkanthan. He's our guest faculty from USA. He's a glaucoma, the chief glaucoma surgeon at Texas Glaucoma Center. He has done fellowship from various institutes across the world, from Shankar Nethralaya to Moorfield to Baskin Palmer. He has got various grants. His main research is interest is glaucoma surgeries, and he has been part of the various glaucoma surgical trials, including TVT, PT, primary trap versus tube. His main research is glaucoma surgery and newer glaucoma surgical techniques. So he's going to talk about the future of glaucoma surgical management. Then the second speaker is George Puthuran. He's the head glaucoma service, Arvind Eye Care, Madurai. He's the pioneer in getting the ADI, in India. Earlier we had only the wild one. His hard work has got the ADI working in India. So, and everybody knows, I'm not going to introduce great detail. All the panelists are all well known, so I will not give, but I'll just briefly introduce everyone. So Padma Shri Dr. Harsh Kumar is a senior glaucoma consultant and director of glaucoma services, Center for Sight, Delhi. Dr. Mayuri Kamar is a senior glaucoma consultant, Okirai Hospital, Ahmedabad, and she's also currently treasurer of Glaucoma Society of India. Dr. Rita Dhamankar, a very senior glaucoma surgeon from Mumbai. He's head of glaucoma services, Lakshmi Eye Institute, Panvel. Basically, we can consider Mumbai. Dr. P. Satyan is director of Satyan's Eye Hospital and Coimbatore Glaucoma Foundation. Earlier, he was head of glaucoma department, Arvind in Eye Care in Coimbatore. Dr. Vanita Pathakresh is senior glaucoma consultant and director glaucoma service, Center of Sight, Hyderabad. Dr. Vinita Ramanis is senior glaucoma consultant, Bansal Eye Hospital, Bhopal. And Shefali and me will moderate the session. So I welcome all the speaker and panelists and all the MOS member, Dr. Taswala sir, Dr. Rajesh. And I will ask the backend team to start Dr. Arvind's presentation. So he'll be talking about future of glaucoma surgery. Ashwin, please ask your team to start Dr. Arvind's presentation.
Greetings from Dallas, Texas. I would first like to thank Dr. Parekh for inviting me to share my thoughts in this webinar on challenges in glaucoma surgery hosted by the Maharashtra Ophthalmic Society. This brings back some very good memories because I was a resident at Nair Hospital in Mumbai in the early 90s. And one of my first oral presentations as a resident was at a MOS meeting in Sholapur. So this is a big circle for me to come back in here and to speak to everybody in Mumbai, which is still, it's my dear heart. It's still in my heart. It's Amchi Mumbai. It never really goes away. So on that note, I'd like to begin speaking on what the future really holds for glaucoma surgery. And I'd like to share my experiences with some neurosurgical procedures for glaucoma in which I have been involved with for the last 5 to 10 years. And the technology seems to be constantly changing. In today's world, when I see a glaucoma patient who needs glaucoma surgery, there are 3 basic options for me. One is I could work with the patient's own drainage system and try and improve it, try and improve the physiologic drainage system, or I can bypass his normal physiological system and create a new drainage system, like a new filtering surgery. Or I also have technology today where I can decrease the aqueous production so as to reduce the intraocular pressure. In terms of improving the existing drainage system, we call them minimally invasive glaucoma surgeries because they're usually really tiny incisions into the eye and they do not involve any conjunctival manipulation. 2 essential services. One, you can have a device implanted into the meshwork, or you can strip the meshwork and work within the canal with no device implanted. In terms of devices, the most popular ones are the iStent trabecular micro bypasses and the new generation iStent inject, and the third iStent Infinity coming around the way, and the Hydrous Microstrand. And we shall talk about these in my talk as we proceed. In terms of trabecular meshwork stripping procedures, you have the Cahook dual blade goniotomy, the gonioscopy assisted transnumeral trabeculotomy, ab interno canaloplasty, omni, and trabectome. Let's come on to what we know and have been doing for the last 50 to 60 years, and that is creating a new drainage system with a trabeculectomy. Express shunts were a slight modification of that. It was not really impressive, and glaucoma drainage tube implants. But technology has now made has made it possible for us to filter the eye through some mini tube shunts, I would call it, without really causing hypotony or collapse of the eye. And one of these is the collagen Zen gel stent, which is a 45 micron opening that essentially filters the aqueous from the anterior chamber to the subconjunctival space. And the second is the pressure flow microshunt, also known previously as the InFocus microshunt, which uses a tube-like device with a fin ray, again, channeling the aqueous to the subconjunctival area. Both of these procedures require the adjunctive use of mitomycin C for it to be successful. And hence, I do not like to really group these with minimally invasive glaucoma surgeries, as there is some amount of morbidity associated with mitomycin C, and I like to group them as less invasive glaucoma surgery. The Zen gel stent is currently available in the United States. The pressure flow is not, but it's freely available in Europe as well as in Canada. Coming on to cycloablative procedures, we sometimes perform an endocyclophotocoagulation along with cataract surgery or combined with other mixed procedures. It seems to add an extra amount of intraocular pressure lowering. And we all are aware of the dicyclodiode procedure with the G probe externally and the more recently approved micropulse diode cyclophotocoagulation, which seems to be gentle and still offers us some relief with intraocular pressure. In terms of mix, there are 3 major outflow targets where you can improve a patient's own drainage system: the Schlem's canal, the supraciliary space, and the subconjunctival space. I already talked about the subconjunctival space in my preceding slide, and the supraciliary space, the CyPass implant is the most popular one, which Alcon bought along the way, but unfortunately they had to take it off the market due to some concerns with endothelial decompensation at the 5-year trial mark. The iStent Supra is still awaiting FDA approval, and there are some rumors around that this CyPass may come back into market with the reference to refractory glaucoma. Let's talk about Schlem's canal procedures, and that would be the basis of my talk today, as I only have 20 minutes and I have time constraint. So with the iStent and the new generation iStent inject wide, we have the Hydrous, and then the trabecular meshwork stripping procedures, the first of which was the trabectome introduced by Neomedics. It needed its own irrigation aspiration system, a separate machine, and was an entire apparatus like buying a separate phacoemulsification machine. More recently, Malik Cahook has introduced the Cahook dual blade goniotomy, And then in Dallas, we developed the gonioscopy-assisted transnumeral trabeculotomy. You can viscodilate the canal with a microcatheter without having to strip the trabecular meshwork, called ab interno canaloplasty. Or you can use the Omni device, which is kind of easier to use, and you can strip 180 degrees of the meshwork. I shall be talking about the procedures highlighted in red today. So Ashton, in a very nicely presented neoprene past way back in the 1950s, showed that the Schlem's canal actually empties into about 30 collector channels, which then go into the scleral plexus, the episcleral plexus, conjunctival plexus, and aqueous veins, yada, yada, yada. And further work by Murray Johnston has shown that there seems to be a preponderance of these collector channels in the nasal meshwork as opposed to the temporal meshwork. So a lot of these procedures really have focused the attention on the nasal anterior chamber angle because there's access to that by sitting temporally and tilting the microscope. However, one of the issues we have with these procedures is that as of today, we do not readily have an outcome marker or device that can tell us exactly how the aqueous is flowing through the open channels. And so how do we even know that the patient benefits from the procedure other than by a drop in intraocular pressure? With traditional filtering surgery, we see a bleb. We see like aqueous around the plate of an aqueous drainage implant. So we know there's some action going on. But here we purely rely on intraocular pressure. There is some movement towards developing aqueous angiography, but I think there is still some time before we see it in development. So why MIGS? MIGS or blebless glaucoma procedures typically lower intraocular pressure to the mid-teens with need for possibly less postoperative glaucoma medications than what the patient was on before. There is a lot of our patients have what we call glaucoma light, and there are some other patients who have glaucoma heavy. The feeling is that there is no need to subject these glaucoma light patients to procedures that form a filtering bleb with all the other issues associated with the filtering bleb, when one could enhance the patient's own drainage system and avoid external filtration. And these procedures seem to work well combined with phacoemulsification. And if these procedures fail down the road, the conjunctiva is still virgin, and therefore further filtering glaucoma surgery is possible. My first procedure I'm going to talk about is the Glaukos iStent, the first generation. It was a titanium snorkel implanted ab interno into the Schlem's canal, and it was approved by the FDA for use in conjunction with cataract surgery in approximately 2012. And you can see in the picture down there, the snorkel is well implanted into trabecular meshwork. For all these mixed procedures, one uses a modified Swan-Jacob gonioscopic lens to visualize the nasal anterior chamber angle. The surgeon sits temporally, the microscope is rotated towards the opposite shoulder, and the lens is placed on the eye. It's a direct gonioscopic view. In the one-year results presented by Tom Samuelson in ophthalmology comparing iStent with cataract and cataract alone, you can clearly see from the two bar graphs that the iStent plus cataract group seems to do a lot better than the cataract alone group at month 12. But to me, a take-home message from this and to a lot of people looking at this study was, oh, cataract itself alone reduces pressure in a significant proportion of patients' eyes, then why do we need to do the iStent along with a cataract? If you continue this study into 2 years, you can see again the phaco plus iStent group, which is the light blue lines, seem to control intraocular pressure better and offer a greater reduction in intraocular pressure, greater reduction in the number of glaucoma medications. At 24 months, patients who received the iStent achieved a 33% reduction in mean IOP and about an 80% reduction in the mean number of medications. And the two lines seem to start to be diverging, wherein the cataract group that had initial lowering in intraocular pressure, now the intraocular pressures are slowly beginning to increase. And we have also noticed the data from the OATH study, which showed intraocular pressure decreased after phacoemulsification, that this effect lasts for about a couple of years. Sorry about that. Oh my God. I apologize for this. So the Canadian group has published even prior about using multiple iStents in the same eye so as to increase the efficacy and the intraocular pressure lowering ability. And they found that when they had 3 stents or so, that they had patients on significantly fewer medications than the 2-stent group at 1 year. Based on this, the glaucoma started developing eye stents where you could implant more than a single stent within the eye. And they developed the 2nd generation eye stent inject device, which are essentially little collar stud devices made of titanium. That's the delivery system down below there. And you can see in the delivery system down there, there's a button that you use to push to inject the eye stent into the trabecular meshwork. And that's a 23 gauge needle injector into the anterior chamber. The eye stents are targeted to the aqueous collector veins. They think the targeting of 2 should theoretically lower intraocular pressure to at or near epistolar venous pressure. When you implant these, you want to look for focal blood reflex areas, where there are the areas of increased segmental TM pigmentations, which might be the area where the collector channels are localized. And ideally, you want to place the 2 eye stents apart by about 2 clock hours. The eye stent inject, the approach is perpendicular to the tissue. There's a trocar, and there's a center needle that pierces the meshwork and delivers the eye stent. You've got to penetrate the tissue with a trocar, lightly press on the TM, and deploy the stent. So this is a little video that actually demonstrates this. Again, the patient has a gonioscopic lens on his eye. You're visualizing pigmented meshwork nasally. That's the trocar and cannula system going into the anterior chamber. The AC is filled with viscoelastic of your choice. I like to use Helon GV. Gentle dimpling of the trabecular meshwork with the trocar system. You press on the plunger slowly as to deliver the eye stent device. And very soon you will see there's a plume of blood, like a reflex that comes about that shows that you have successfully implanted the device into the Schlem's canal by piercing the trabecular meshwork. And then what you do is you turn the trocar and cannula about 2 to 3 clock hours away again, where there's visualization. And again, repeat the process so that you're able to implant 2 eye stents separately. Next, I'm going to talk to you about the Hydrous Microstrand. The Hydrous Microstrand is made of nitinol. It's a flexible nickel titanium alloy. It's 8 millimeters long and is designed so as to follow the course of the trabecular meshwork and Schlem's canal. It's crescent shaped and it scaffolds the meshwork, and it's also designed to be implanted ab interno through a 1 to 1.5 millimeter incision into Schlem's canal. It has a trimodal mechanism of action, wherein you're bypassing the trabecular meshwork with this little area here. And the whole stent actually dilates Schlem's canal through these little 3 windows, and it covers approximately 90% of the circumference of Schlem's canal. Therefore, it actually covers a lot more area and possibly more collector channels. The multi-center controlled trial, which is called the Horizon study, published in Ophthalmology, comparing phaco alone to phaco plus hydrous in patients with mild to moderate glaucoma, showed significant reduction of intraocular pressure and medications after 24 months with the hydrous group as compared to the phaco alone group. So if you look at these 2 bar graphs at 12 months and 24 months, you can see that the eyes with the phaco plus hydrous had a significant reduction of greater than equal to 20% reduction in intraocular pressure compared to baseline. And again, there was the drop in mean change in IOP was also greater in the hydrous plus phaco group as to the phaco group alone. This is the hydrous video courtesy of iComet, and I'm going to let this video play along with the audio so they can see it.
The Hydrous Microstent is implanted into the eye using an ab internal clear corneal approach. The incision is made to the right to allow for the curvature of the cannula, which you can see is uniquely curved to follow the curvature of the angle as you see in its position. The distal tip of the cannula is used to incise the inner wall initially. Only about 100 microns of that distal tip will actually enter the canal. You'll see that there is some torquing of the eye, which is expected, some positive pressure onto the canal to allow penetration. But once this occurs, we will relax our hand slightly and advance the roller wheel to place the device into the canal. Notice how the device is slightly placed in an upward fashion to ensure we have adequate passage. And at this point now, we relax our hand, releasing the tension against the outer wall and allowing the implant to be smoothly directed into the canal. The site interlock releases the inlet from the implantation device, and the cannula is then withdrawn. And we'll now take a look and see the device in its position here as you see the inlet to the right and the 3 windows to the left. There's normal blood reflux in this case. In fact, it actually helped us to visualize the canal position prior to implantation. And we will now evaluate the position of the device using a Sinskey hook just to manipulate the eye. Notice as the eye is torqued down, you can see 3 windows nicely positioned within the canal, which is where we expect it to be. You'll see the blood reflex behind those 3 windows present in the canal, scaffolding the inner wall nicely and keeping the canal open. The Hydrous Microstrand is a
So that is Ike, right? He's the excellent surgeon, and it's not as easy as what he shows it to be, but you can actually achieve good results with practice and paying some attention to what you do. Next, I'd like to talk to you about the COMPARE study, which is I think one of the first head-to-head mixed studies, which compares the iStent with the Hydrous as a standalone treatment, not combined with phaco. It was done in a prospective multi-center fashion, and again, comparing the two at about 1 year. They recruited 152 eyes with primary open-angle glaucoma with preoperative intraocular pressure varying from 23 to 39 after a washout of medications. And if you look at the 12-month results, the Hydrous had a greater complete surgical success and reduced medication use. A lot more Hydrous patients were medication-free at 12 months. Nearly 50% of them were medication-free as compared to a quarter of patients with the phaco plus of the iStent alone. Secondary glaucoma surgery was required in 2 eyes in the iStent inject group and none of the eyes in the Hydrous group. So the Hydrous clearly seems to perform better than the iStent inject, at least in the studies that we have seen right now. Though I think technically it's more challenging to be implanted as it's a bigger piece of metal and has to be situated properly within Schlem's canal and should not slide into the suprachoroidal space. Next, I'd like to start talking about trabecular meshwork stripping procedures. And the first one I would like to talk about is the gonioscopy-assisted transnumeral trabeculotomy. This achieves 360 degrees of opening into Schlem's canal. It's minimally invasive. It requires corneal clarity. And we started out using a 250 micron illuminated microcatheter, but this procedure can be done with a 5O or a 6O protein blue suture, which the tip is blunted as you pass it through Schlem's canal. But it does require microsurgical instrumentation to manipulate the catheter or the suture within the anterior chamber. This procedure was born out of previous experience with external 360 trabeculotomy for treatment of congenital glaucoma, which a lot of us glaucoma folk have been doing for many years. But with the advent of the microcatheter, we were able to very successfully pass the catheter through Schlem's canal for 360 degrees, as you'll see in the subsequent video. And with modern technology and microsurgical instrumentation, we were able to achieve the same internally internal. So this is one of the GAT procedures that performed one of my earlier ones way back in 2012, 2013 with a 250 micron microcatheter. I chose to show this because it very clearly demonstrates proof of principle. So you can see the eye is filled with viscoelastic. The catheter is placed in the eye. The eye is tilted. The gonioscopic lens is brought on fungible field. With an MVR blade, we create, a goniotomy into Schlem's canal by cutting through trabecular meshwork. You have to create a decent sized goniotomy incision so as to have enough access into Schlem's canal. Using the microcatheter, using the microforceps, the microcatheter is then fed into Schlem's canal very gently and slowly. And as it's fed along, there's a lighted beacon tip at the end of the catheter, and you can see it starts reappearing along the limbus towards the nasal area. Now you know that you've traversed through nearly 360 degrees of Schlem's canal. And you'll notice in the gonioscopic view now that the lighted beacon tip reappears, telling you that the catheter has now gone through the entire Schlem's canal. You got to be very careful when feeding the catheter to the canal, making sure it's not kinked, because kinking it can sometimes damage the iris and cause a cyclodialysis cleft. Once this is done, 2 ends of the catheter are then pulled so as to strip trabecular meshwork for a total of 360 degrees, creating access for the aqueous to flow into the collector channels directly. One of the side effects of this procedure is the hyphema and reflex heme in the anterior chamber, which gushes in sometimes if there's inadequate viscoelastic in the eye. But elegant procedure and not very difficult to perform. So at a 24-month follow-up reported in literature of 198 patients, in primary open-angle glaucoma alone, there seemed to be a 9.2 millimeter decrease with a reduction of about 1.4 medications. The reduction was more significant in secondary glaucoma eyes, where it reduced intraocular pressure to a mean of 14.1 with a medication decrease of 2. The cumulative proportion of failure at 24 months varied from 0.18 to 0.48. And as I alluded to previously, transient hyphema is one of the most common complications because you're opening up a greater degree of trabecular meshwork, greater access to collector channels, so more reflux heme into the anterior chamber. But it really is not a significant problem once you know how to deal with it. You sometimes have to leave a little bit of viscoelastic in the eye at the end of the case so that you have the eye is pressurized and the heme does not flow into the anterior chamber. Next, I want to talk to you about the Cahook dual blade. The Cahook dual blade is design features. It has a little pointed tip that pierces through trabecular meshwork. It has a ramp that now elevates and stretches the trabecular meshwork at either side. And has a foot plate or a heel that prevents damage to the anterior wall of the canal, as these two little blades excise an entire strip of meshwork. Why do you want to excise a strip of meshwork? Because if you did a goniotomy alone with a needle, which we've done for congenital glaucoma in the past, there's a chance that the two leaflets of the trabecular meshwork can fuse back and recanalize the Schlem's canal. This is a video of Cahook dual blade goniotomy. Again, nasal anterior chamber angle, well-pigmented meshwork, viscoelastic in the anterior chamber. Helan GV is my choice of implant. The Cahook dual blade is in the anterior chamber. Under direct visualization, is placed into Schlem's canal, pulled slightly anteriorly, and then moved to one side so as to strip the trabecular meshwork. Once you think you've stripped enough trabecular meshwork on one side, you can bring the blade back to the center of the AC and then gently turn it around so as to now strip the other side as well, so as to create a decent, about a 100 to 120 degree arc of a cleft into Schlem's canal. Sometimes there's an overlying strip of the meshwork dangling, and I would take microsurgical forceps or Utrada's forceps and go in and peel it off. So goniotomy with a single-use blade, short-term results. So at about 6 months with Greenwood study, it seemed to reduce intraocular pressure about 4.6, and there's a mean reduction in intraocular pressures by about 0.7. As you can see in the picture here, post-operatively, if you ever did a gonioscopy, you would see a nice white line where pigmented trabecular meshwork existed before, showing you that the meshwork had been stripped, and what you're seeing is essentially the outer wall of Schlem's canal. At 12 months, in angle closure eyes where they had done a little goniosynucleolysis and there was some amount of meshwork visible, a retrospective analysis showed that with a preoperative intraocular pressure of 25.5 and medication use of 2.3, it got reduced to about 12.3, nearly half, and medication use also reduced by about 2.2. Nearly 93% of patients achieved an intraocular pressure under 18, and over 100% of patients in this study achieved an intraocular pressure of greater than 20% reduction. So if you compare phaco-Cahook or Cahook dual blade along with phaco-iStent, again a prospective randomized controlled trial of 2 head-to-head mixed studies, 164 patients enrolled. Both surgeries seem to lower intraocular pressure well, and the need for intraocular pressure lowering medications post-operatively. Significantly more Cahook blade eyes seem to achieve the target pressure of greater than 20% reduction in intraocular pressure or greater than 1 medication reduction at month 12. We are in need of more head-to-head studies of mixed procedures such as this so that we know which particular procedure we'd like to use in a particular patient. Currently, all of us are trying to be versatile and learning to use multiple techniques so that we can use them in different patients and customize our treatment for a particular patient. So in conclusion, I think this webinar today is going to talk about how we can reduce intraocular pressure to surgically manage our patients, as intraocular pressure reduction has been proven to be the best treatment for glaucoma. I believe that you should consider surgical options early if the patient is intolerant to medications. Because of MIGS, you now offer options for surgical management of earlier glaucoma without having a bleb and all the problems of the bleb down the road. And if the patient is going to cataract surgery on one or more glaucoma medications, I think it's proper to combine it with some kind of mixed procedure so as to reduce the postoperative burden of anti-glaucoma medications on the patient and also reduce the chance of an intraocular pressure spike. So if a patient needs a very low intraocular pressure, like advanced glaucoma, fixation-threatening scotomas, low-tension glaucoma, I have no qualms in performing a trabeculectomy or a glaucoma drainage procedure. Along with that comes the risk of the bleb and associated lifetime bleb vigilance. However, as I alluded before, a lot of patients do exceedingly well with postoperative intraocular pressure in the middle teens on one medication, and that is achievable with the newer minimally invasive glaucoma surgeries. So I would ask you today to certainly consider angle surgery for your adult open angle glaucoma patients. Among all the procedures that I've talked to today, I'm not really sure any one of them are available currently in India for your use. But certainly the GAT procedure is performable with a simple 5-0 proline suture or a 6-0 proline suture. On that note, I'd like to end this and thank you all again for inviting me and thank you for spending your evening with me. I apologize, I'm unable to attend your panel discussion due to prior engagement. I wish you all the best and thank you.
So that was Arvind's talk. He has elaborated very nicely the future. We'll discuss it later during the panel discussion. I request Dr. George Puthuran to start his talk. He'll be talking about his take on the primary tube in open angle glaucoma. George, please.
Good evening, everybody, and thank you very much, Doctors Rajul and Shefali, for this invitation. I hope I'm audible and my screen is visible.
Yes, yes.
Yeah.
Yeah, please go ahead.
Yeah. So when actually Dr. Rajul first gave me this topic, I was wondering why 15 minutes for a one-slide presentation. Actually, primary tube shunt surgery implies an eye without prior incisional ocular surgery. And my initial impression was there's absolutely no indication in primary open angle glaucoma for a primary tube shunt surgery. Then we looked at a little bit of relevant literature, and I also kept my eyes open to see whether I could gather any anecdotal evidence from our practice. So this is a very relevant literature. Practice Preferences for Glaucoma Surgery, a survey of the American Glaucoma Society, the purpose of which was to assess surgical practice patterns among the American Glaucoma Society membership. It was an anonymous online survey evaluating the use of glaucoma surgeries in various clinical settings, was redistributed to AGS members. Survey responses were compared with prior results from 1996, 2002, and 2008 to determine shifts in surgical practice patterns. As you can see, there has been a mean percentage decrease in the use of trabeculectomy with mitomycin across all clinical scenarios from 96 to 2016. In the same period, the mean percentage use of glaucoma drainage devices shows a progressively increased uptake, and but trabeculectomy with mitomycin remained the most preferred primary surgery for primary open angle glaucoma among AGS members. So this is the relevant portion of this article, which is relevant to our discussion today. POAG without prior incisional surgery. As you can see, the percentage of surgeons who adopted trabeculectomy with mitomycin, this question was actually introduced only in 2008. So the percentage of surgeons who prefer trabeculectomy with mitomycin reduced from 74% in 2008 to 59% in 2016. And the percentage of GDD in primary open angle glaucoma as a primary incisional surgery increased from 11 to 23% in 2016. What they said was the primary glaucoma procedure of choice in patients with POAG without prior ocular surgery was first introduced as a survey question in 2008. Trabeculectomy with mitomycin remains the most popular operation, but the use of GDD has since doubled. This was not convincing to me. to take up a primary tube surgery in a primary open angle glaucoma patient. Another very relevant article, treatment outcomes in the primary tube versus trabeculectomy study after 3 years of follow-up. This was unmasked multi-center randomized clinical trial where 242 eyes of 200 patients with medically uncontrolled glaucoma and no previous incisional ocular surgery were included, 125 in the tube group and 117 in the trabeculectomy group. Patients were enrolled at 16 clinical centers and assigned randomly to treatment with a tube shunt, a 350 millimeter square Barwell glaucoma implant, or a trabeculectomy with mitomycin C. I am not sure whether many of our ethics committees would have allowed many of our institutes to go ahead with such a randomized clinical trial in the present setting. Again, primary open angle glaucoma was the major contributor for this study, 109 patients each in the tube group and the trabeculectomy group. So what the authors concluded that the PTBT study, the primary tube versus trabeculectomy study, did not demonstrate a clear superiority of one glaucoma operation over the other. Both surgical procedures were effective in lowering intraocular pressure in patients who had not previously undergone incisional glaucoma surgery. And greater IOP reduction with use of fewer glaucoma medications was achieved with trabeculectomy with mitomycin. Again, not convincing as far as today's topic is concerned. Then I could find a retrospective comparison of primary Barwell glaucoma implantation with trabeculectomy with mitomycin. A total of 125 patients with low-risk glaucoma undergoing primary glaucoma surgery, including 55 patients who received a 350 millimeter square Barwell glaucoma implant and 70 patients who underwent trabeculectomy. Again, primary open angle glaucoma, the major contributor, 45 patients went into the Barwell group, a primary Barwell in a POAG, 40 patients, a primary trap in a POAG. Again, similar rates of surgical success were observed after trabeculectomy with mitomycin and Barwell implantation in patients undergoing primary incisional glaucoma surgery. Trabeculectomy with mitomycin tended to produce lower intraocular pressure with less use of adjunctive glaucoma therapy compared with Barwell implantation. Still not convincing. So I also got a few clinical scenarios from our clinic. This was scenario number 1, a 63-year-old male with family history of glaucoma presented for a routine checkup. And this was the findings. 6 best corrected, baseline intraocular pressure 40 and 50, gonioscopy wide open angles, early lens changes, advanced cupping in the left eye, and a moderate to advanced cupping in the right eye. This is the right eye picture where he had an inferior rim loss till the inferior disc margin, and this is the left eye with almost a near total glaucomatous optic atrophy and quite severely affected visual fields. And here was a patient, he was started on maximal medical therapy, and despite good compliance, his pressures remained around 40 millimeters in both eyes on subsequent visits. We decided to go ahead with a primary left eye Ahmed glaucoma implantation under guarded visual prognosis. Fortunately, he did well. Left eye doing well post AGV, 14 to 16 millimeters is a primary AGV, while right eye remained persistently high with 42 to 48 millimeters of mercury. Subsequently, we went ahead and did a primary AGV in the second in his right eye too. This is the case scenario 2, relatively young male, monoocular POAG with history of glaucoma in the mother. This is a first visit. Right eye 660, improving to 612, left eye no light perception. Again, very high baseline intraocular pressures, 58 in the right eye, 62 in the left eye. He was phakic, posterior subcapsular with the posterior polar component. Advanced cupping with split fixation in the right eye, extremely non-compliant. Even right eye IOP remained around 50 millimeters on maximal medical therapy. We even had a sitting of post micropulse transmural cyclophotocoagulation in his right eye. So this is the right eye, near total glaucomatous optic atrophy. Left eye, this was the typical corneal haze due to very high pressures, wide open angles, both eyes, very poor view of the left eye fundus. Again, we went ahead with a primary Ahmed glaucoma valve implantation in his right eye. Immediate post-op, he had a shallow AC with tube embedded in the iris. Fortunately, over a period of one week with conservative treatment with atropine and steroids, chamber formed. Case scenario 3, 53-year-old, another relatively young female referred to us for poor IOP control on medical therapy. She was a known case of glaucoma for the past 20 years, undergoing treatment elsewhere. This was the best corrected visual acuity, though she was myope, high myope. Pressures were very high, 40 millimeters on maximal medical therapy in the right eye, 32 in the left eye, axial lens myopic. Moderate glaucomatous excavation, 0.75 in the right eye, 0.65 in the left eye. This is the right eye picture with inferior rim thinning. This is the left eye, a myopic disc with moderate glaucomatous excavation. So we went ahead with a primary non-valve device with supramed stenting for this patient. Supramed removal had to be done post-op day 48. She's doing well. Her IOP 1 month post-supramed suture removal in the right eye was 12 millimeters of mercury. Left eye again continues to be at 47 millimeters of mercury, scheduled for an RD with supramed stenting. Case scenario 4, another young male, known case of primary open angle glaucoma on maximal medications. This is a patient with best corrected visual acuity of 460 in the right eye, 660 in the left eye, intraocular pressure 35 and 42, thin corneas, early lens changes, and near glaucomatous optic atrophy in both eyes. So these are patients who come into our OPD they look almost, there is very severe glaucoma accounting for loss of visual acuity. And they almost walk in severely visually impaired. Still risked primary AGV in both eyes. His intraocular pressures are remaining in the about 16 to 18 in both eyes on a fixed combination. So choice of primary surgery in primary open angle glaucoma depends on a lot of factors. Surgeon's experience and comfort with each procedure is a factor. Tolerance to medical therapy, target level of intraocular pressure reduction, and risk of postoperative complications. My concern with a primary tube in POAG is what if the primary tube fails? And ours being a relatively high volume tube practice, and it's not very uncommon for us to see tubes failing for no reason. There were no tube related complications. Probably it is the capsule thickening at the plate. And this was a patient who presented very recently, one trabeculectomy done, another triple done, then had a tube around 4 to 5 years back, a non-valve device, and presenting with 40 pressures on maximum medication. She already also underwent a cyclophotoregulation in between, and we had to risk a second tube to preserve this. She was a monocular patient, relatively young, and we had to risk a second tube to try and preserve some useful vision for her. I would position the tube after trabeculectomy has failed in primary open angle glaucoma. Exceptions are those scenarios which I discussed: advanced glaucomatous optic nerve head visual field loss with IOP highly refractory to max medications. And when there is severe glaucomatous damage and visual field loss, we would prefer to put in a valve device to minimize the risk of hypotony-related complications. Moderate glaucomatous optic nerve head visual field loss presenting with high intraocular pressure in a high myope on maximum meds, we prefer to risk the non-valve device because efficacy in long term may be better. And if we do not exclude cataract surgery in this primary tube in POAG, probably in our part of the world, manual small incision cataract surgery is a definite indication for primary tube in POAG not controlled with medical therapy, because the incision is much posterior and sometimes it's very difficult to do a trabeculectomy in these patients. And another relative indication could be a highly compromised conjunctiva due to chronic topical beds. So this is another very interesting article I found. Very recent 2020, where they have compared treatment outcomes from the PVT and the PTVT studies. And I was quite surprised to see this. In both the PTVT and the TVT studies, the efficacy of tube shunt surgery relative to trabeculectomy with mitomycin was greater at higher levels of preoperative IOP. Patients with lower preoperative intraocular pressure benefited most from trabeculectomy with mitomycin over the tube shunt implantation in the PTVT study. A preoperative high intraocular pressure in POEG is not entirely convincing to me to go in for a primary tube, but when coupled with significantly advanced glaucomatous disc damage, or probably in a high myope, this is compelling evidence to go in for a primary tube in primary open-angle glaucoma. Acknowledgement for the day is a colleague of mine, Dr. Kausalya, who works with me at Arvind Eye Hospital, Madurai. Thank you once again for this opportunity. Thank you.
Thank you, Dr. George, for such a wonderful talk. And I would also like to thank Dr. Arvind. So though he's not present, but it was definitely very, very educative and wonderful talk. So I think all of us will have a lot of questions also. So maybe I'll start with Dr. George first. It is regarding your tubes only. Like if in advanced glaucoma, if given a choice between AGV and ADI, which one would you prefer?
Yeah, so if it is an advanced glaucoma definitely nowadays we prefer to put in the valve device. The risk of hypotony related, I'm audible?
Yes, you're audible. Yeah. Yes, you're audible.
Yeah. So in advanced glaucoma, we don't want to risk hypotony related complications with a non-valve device. So definitely, that is one definite indication for a Ahmed glaucoma valve implantation.
So basically, in advanced glaucoma, to prevent the complication related to the hypotony, I think then valved implants are much better choice, because I think you are the right person because you do both the implants. And one more question I have, and I think if any other panel, if you have question to Dr. George, definitely you can ask. So sir, another question is in case of if there is a fibrosis around the plate, so how do you manage? We have seen in a lot of patients due to fibrosis, the pressures, for up to 3 to 4 months we expected, but sometimes even later on the patient is having a lot of fibrosis. So how do you manage this type of patients?
Yeah, so this is one definite advantage of the barbell-like design over the Ahmed glaucoma valve. Most of these pleb encapsulation tenon cysts are much more common with the valve Ahmed glaucoma valve, and we see much lower profile, larger surface area, thinner capsules around the barbell-like design episcleral plate of the RD, which is contoured to the shape of the globe. Believe me, the rate of these bleb fibrosis, refractory bleb thickening encapsulation is much less with the RD. To treat the Ahmed glaucoma valve, the bleb fibrosis and bleb encapsulation for the Ahmed glaucoma valve, everybody talks about, even we do that, immediate post-op, right from first day post-op, we start aqueous suppressants in Ahmed glaucoma valve. And still, I agree with you, Dr. Shefali, there is a lot of bleb thickening and hypertensive phase in the AGV rather than the RD. We have also published our results of hypertensive phase with the RD, and we were surprised that 30% of patients with the RD had a hypertensive phase, but they were much less refractory compared to the AGV. Most of them responded very well to aqueous suppressants. And even for Ahmed glaucoma valve, I think it's just keep adding aqueous suppressants for the bleb fibrosis. I don't think earlier we used to do needling. We started with the needle to aspirate fluids in these AGVs. They never worked. Then we tried bleb needling. We tried mitomycin. Finally, we even excised a portion of the capsule underneath the conjunctiva around the episcleral plate. But I think most of these procedures don't last long. And probably if once bleb fibrosis occurs, we have the option of cyclophotocoagulation or another repeat tube.
Yeah, I agree, because even after doing everything, still we have few percentage of the patients where this fibrosis and this hypertensive phase or whatever the high IOP cannot be managed. So I think any other question, anyone asked?
Yeah, I think Dr. Vanita wants to say something.
Yes.
Yeah. George says he does not prefer an ADI. I say I prefer an ADI.
No, he said only the advanced glaucoma, he said.
No,
not in every
even in advanced glaucoma, believe me, so, I feel I do a thorough job completely occluding the tube and I use actually 2-3 occlusive sutures. They don't open at the same time. At least I don't think they open at the same time. It's a slow decrease. So I actually prefer. But I agree, if I have a patient who's one-eyed and very advanced glaucoma, then I would consider an glaucoma valve. And all those NVGs and all that, but I have used both in both, and the net result definitely is that AGVs don't do as well. And I if I can help it, I would use the ADI. But I am not sitting in a big institute anymore. I have to think about my practice. So where I anticipate that more interventions are required, if I'm using an ADI, then I probably do not use it. Cost sometimes determines the choice of implant. But what I am interested in is a question to George, actually. Is Supramid now available, Oral Labs?
Will be available within a month. The shelf life study is just getting completed. I have always the privilege of.
I'm so waiting for it.
Yeah. It is very, very affordable. Probably they are going to just supply it free with an RD.
Okay. Oh, that's wonderful. That's wonderful.
I had the privilege of using the Supramid, and I feel so much more comfortable. I have an absolute control. The eye doesn't just collapse like that when the YouTube ligature. I think Supramid is going to be a game changer for non-valve devices also.
Yes.
And probably 2 years from now, advanced glaucoma, I might say RD with Supramid.
I have to say that the real problems I have had in RD, I have not had, thankfully, touch wood, too many. I've had a persistent hypotony in uveitic eyes, which do behave a little bit this way, that way. And in a Sturge-Weber syndrome, where the patient had choroidal hemangioma. Other than these, in that particular patient, just a week ago, I put in a Proline intraoperatively. Intraocularly, I put in a Proline stent. Got rid of the hypotony, basically. But if Supramid is available, I'm sure it's going to make a lot of difference.
Yes, yeah. Dr. Puthuran, you want to say something?
Just one point here, just to add on to what Dr. Vanitha said. Every uveitic glaucoma in our institute gets an AGV. None of them gets an RD, because uveitic glaucoma.
But I've had problems in AGV also, in uveitic glaucoma. I
think the bottom line is that high risk cases, I think AGV is still I think everyone will agree that AGV in high risk cases, and depending on the surgeon's experience, AGV is preferred. And maybe if the cost is an issue, then maybe ADI. And of course, there are indications of ADI also, but in high risk cases at this point of time, I think everyone prefers AGV. So any other questions to Dr. George? Or otherwise, we will open a panel discussion for general ophthalmology.
One question. If again, suppose you're not sure whether the patient is going to come back for follow-up, would you prefer an AGV over ADI if the follow-up is going to be dicey?
Nice seeing you, sir.
In the case of, in that phase when it's going to be, you don't know whether it's going into hypotony, when the thing opens up.
It would be, yeah.
Yeah, so first of all, nice to see you, sir, after a long time. Second, if it is a patient who is a long distance patient and who is not a very high risk patient, probably an RD is a better choice, because it needs much less shepherding post-operatively compared to the AGV.
Okay, fair enough.
I have seen in many patients coming back after 1 year, 2 years, doing extremely well, and I'm thrilled to see those.
One of the major issues is that you have had a huge experience, but I don't think most of us have had. I think Vanitha is saying, but at least we have not been able to go so much to your ADI than as compared to AGV. So I think we are really not capable of speaking so much on that.
I think Dr. Rita has to say something. Yes, madam.
Yeah,
please.
I just wanted to say, what happens to people who are staying far away, and what if they have hypotony come what may, if you've used an ADI. Don't you fear that? I mean, that is something that I'm always worried about.
But those patients actually can recognize that they will be back. They will. You will have to give them some kind of a contact, somebody there who can take a look, and they invariably come back. And this hypotony, when the tube ligature suture lyses, it's transient. Usually within 48 hours, AC forms very well.
And the other question that I had to you, George, was that
I think Dr. Rita.
Yep.
So basically, the follow-up, when the patient complies, adherence is an issue, follow-up, I think both is problem. Because the AGV, there would be a hypertensive phase, and if it doesn't come, here hypotony. So both extreme, but both is problem. So I think the patient has to come for regular follow-up.
I think these are where we do tubes mainly, which are, refractory cases, which are very advanced glaucoma. So I think these patients we need to counsel before, and only we will need regular follow-ups, and only then we should go ahead with this type of surgery.
Well, it's not that you don't need follow-ups in TRABs.
Every
you do.
follow-up is
a different issue.
Follow-up in glaucoma surgery.
And choroidals are not that uncommon. With the advanced cases, you may have choroidals. With the tube in the choroidals and then the plugging of the tube, and this is all so scary. So it cannot be taken lightly when you work on the.
Sorry, I had another question for George. In the case where you talked about posterior subcapsular cataract as well as PPC component, why wasn't the lens taken out? I actually, if there is cataract, I take out the lens, I put the tube in the sulcus. My primary positioning now, default positioning is the sulcus.
Dr. Vanitha, this is a very, very rare occasion when the patient had corneal haze and corneal epithelial edema with almost near glaucomatous optic atrophy and 45 to 50 pressures. We were not comfortable doing a combined procedure. We wanted to, first we tried a micropulse, then we did a AGV. Very, very rare. But otherwise, usually if there's a cataract, 99.99% we do the cataract and then the tube.
Yeah, and my publication of mine is pending, not primary implantation in primary glaucoma, but definitely in secondary glaucoma. I presented that at GSI, and Rajul was one of the judges there. I don't know if he remembers.
No, that is not a.
Yeah, Dr. Puthwala.
No, primary tube in secondary glaucomas is not as much of a controversy as primary tube in primary open-angle glaucoma.
Yes. I agree. But still, even then, you will find that people are doing 1, 2, 3 trabs before they are actually trying the tube.
It depends on the surgeon's comfort and experience levels also in such a scenario. And especially if the conjunctiva was totally untouched. Even for if totally untouched conjunctiva, you could try a high mitomycin dose trabeculectomy, even for secondary glaucomas. No harm.
Yeah. So I think if I have done first rep, I'm more comfortable doing second rep. If somebody else, not non-glaucoma specialist, then I don't know how they manipulate the conjunctiva. Then to give the success rate the way we want to give, I think it's become difficult. So second, I usually shifted to second surgery as tubes rather than second trap. Unless I have done, then I don't mind doing second trap. Then I know that I would have not manipulated conjunctiva other than the area which I have operated. Yes, Sifal, you can.
Yeah, so I think now we, for the sake of general ophthalmologists, there are a few questions. Yes, Dr. Vinita, you want to say something?
I want to ask Dr. Jaj, do you have any special consent or any counseling for POAG patients, whether to do ADI or AGV, whether you consider patient into that counseling, that whether they want AGV or ADI?
No, we usually don't give them a choice, ma'am. We usually see most of the primary open-angle glaucomas go directly into the trabeculectomy counseling. It's not a tube. So once we decide on a tube in a primary tube in a POAG, we have to be extremely careful. We take the decisions and inform the patient of what the plan is. And then, of course, all the attending counselings about post-operative visits and risks of further visual loss following surgery, even to the extent that you need to also tell them that probably there's a mild risk of loss of light perception also in such patients.
I think so.
Especially for one-eyed patients, when you are trying directly tube, I think we should take that into consideration.
Okay. So, sir, my first question is to Dr. Harsh, sir. So this is the very basic questions I am going to ask. Sir, do you prefer giving hyperosmotics or like IV mannitol before any glaucoma surgery, or there are few select indications when you would prefer giving this hyperosmotics?
First thing is that if you have to give, you have to be very careful that, especially for the general practitioners, you better be, either you are equipped with an anesthetist over there, and you have very clearly taken a history. We have had problems with patient going into CHF after giving mannitol. Or you should identify a hospital nearby where you can rush the patient. So don't take giving mannitol lightly. Since we have the full setup, then I prefer to give in patients who have high intraocular pressures pre-operatively despite everything. Then we would prefer to give a mannitol, but time it exactly, and the peak usually comes around 30, 40, 50 minutes later. And then there'll be a rebound. So don't end up operating a patient when there's going to be a rebound. And so we will like to give the mannitol in cases where the pressures are not controlled and the pressures are high pre-operatively. So
in
whatever
angle closure,
so
sir, in angle closure,
whichever, even in OAG, if the pressures, sometimes the pressures are way high, then I would definitely like to give. And the pressures, if despite mannitol, the pressures remain high, sometimes we even like to do a vitreous decompression slightly.
Okay. Okay. So basically, I think everyone must be agreeing that that when the pressures are high, definitely we should give hyperosmotics to prevent the sudden decompression, to prevent the any sudden hypotony related complications and like suprachoroidal hemorrhage, that should be given. And I think one more point that Dr. Harsh Kumar has highlighted is that mannitol should be given under the physicians there has to be, and we usually whenever we give mannitol, there is always an anesthetist because it can cause severe life-threatening complications, so that we must take care. So I think more or less everyone agrees. We prefer to give the mannitol even in the angle closure pressure glaucoma patients, because what we have seen, there is a lot of antechamber fluctuation. Even if the pressures are normal, then there are a lot of this fluctuation in the AC while operating, especially when doing the cataract surgery. In those patients, definitely we prefer giving mannitol. So I think here, anybody having another view, or shall I go for another question?
No, I give in a very, very advanced case where there is a split fixation or wipeout.
Yes, that is another. Yes,
in those are the cases I prefer to give.
Yes, Rita madam.
I also like to give Diamox before operating, and then even with the Diamox, if the pressure has not come to where we need to, so I give them, Diamox 2 hours before the surgery, and then if the pressure is not okay, then I'll think of the mannitol.
Yes. So madam, next question to you only, Dr. Rita madam. So would you like to stop certain anti-glaucoma medication before cataract surgery, or do you continue the medications?
So the thing is that since the medications that we are using are not really working, and we know that there's a lot of conjunctival toxicity that has already occurred, I stop my prostaglandins about a week before, and 2 weeks before surgery, I start them on FML, so that I get a relatively quieter conjunctiva. And therefore, I think that, the results post trabeculectomy are definitely better off with a quieter conjunctiva. Of course, I don't use pilocarpine regularly, so I don't use pilocarpine.
But if patient is on pilocarpine,
we will definitely stop the pilocarpine. We will stop the pilocarpine.
Yes, because it gives a lot of inflammation. So in fact,
absolutely.
We don't prefer giving.
And the problem is, supposing you are doing a combined surgery, and you have a nice dilated pupil for the cataract, and then you want to switch on to use pilocarpine intraop. That is, I think, really, you have to be very careful. Just inject the pilocarpine and wash it off as quickly as you can.
Agreed. So any other view on this, or everyone agrees?
So I did not understand. You're asking cataract surgery, or you're asking
No. When you're doing a combined procedure, so before trab, If you're doing a combined procedure, then you have a nice dilated pupil, and you don't want to do a iridectomy in that dilated pupil, because you don't really gauge at that point in time how much of the iris you're cutting, because the iris is all sort of crunched together. So at that time I would like a mid-dilated pupil. But if then I have to inject pilocarpine, I quickly inject pilocarpine, wash it out as quickly as I've given it, so that I'm sure that there is very little debris of pilocarpine left, because otherwise you get a very bad post-op reaction. Uveitic reaction, inflammatory reaction that you get is really bad. So it's best to wash it off completely, and as quickly as possible.
What I understood from Shefali's question is that she's asking whether you stop any medications before cataract surgery.
No.
Before cataract or before glaucoma surgery. It was in general before surgery.
So then why would you stop a prostaglandin analog?
I would stop.
A lot of people, they stop at least 1 week before any surgery, because prostaglandin analog may cause inflammation, it may cause post-op CME. So, but I think we don't stop prostaglandin, but I think there are a lot of people who stop prostaglandin.
There is no conclusive evidence. There's only anecdotal evidence, actually speaking.
So, yeah. So, but anyway, it is surgeon's choice. A lot of people, they stop prostaglandin 1 week before. So, I think Dr. Harsh sir,
also,
so you want to say
yeah. Actually, I didn't want to do it, but somehow the other people read the net. I don't know where it is written, but somewhere it is written that you, at least before cataract surgery, you should stop it. And so they come and ask that, why have you not stopped? So I really don't know. I wonder if somebody has read the net and what the hell is given on that.
No cataract surgeon likes to have prostaglandins on. Any cataract surgeon you ask, they will say they will not want to have their prostaglandins. So they will send the patient to you and say, can we stop the prostaglandins? How much in advance can we stop it? When do you want us to start it? All of these questions are real life questions.
At least we stop prostaglandins after cataract surgery. Definitely we don't. And anyway, after doing cataract surgery, most of the time pressure reduces to some extent.
It makes sense that if you have complications during surgery, then you stop it. If there's a PC rent or if there's a vitreous loss, then it makes sense. But otherwise,
there can be subclinical CMEs. I think prostaglandins belong to that group, and we prefer.
Yeah, if you are expecting something like that to happen, then maybe you can stop. And if you are actually going to stop, you have to stop for 3 weeks, which nobody does. So it is a joke anyway.
But I have a question for the panel.
Anita, the reason of stopping is that after cataract surgery, anyway, pressure is going to be down for at least few months. So if one drug has to be stopped, then we stop prostaglandin.
That's right.
That is the logic. So after surgery, anyway, the certain number of glaucoma medication,
I would keep
we can easily stop for a few weeks.
So I think there are different views. So if you want to stop prostaglandin, you can, but at least if there is some complication, definitely we should stop prostaglandins. That is that is what I will suggest. Yes, Dr. Vanita.
I have one question for the panel. I have quite frequently seen both prostaglandin analog as well as non-steroidal anti-inflammatories being given at the same time. What is your view? I thought non-steroidals work on the prostaglandin pathway. And if you are giving a prostaglandin analog, then it is quite likely that it is actually
we are not giving any NSAID. So if anybody giving that, then I think they can discuss. So we normally, if we are giving steroids and post-operative, we have to give steroids. We are not adding any NSAID unless and until there is some CME or there is that component of CME something, then only we are giving it. Otherwise, we are not giving any NSAID. And I don't think anybody on the panel is giving it. So I think my next question to Mayuri madam. Madam, do you like to stop any systemic medications before the surgery? And which medication would you consider?
Basically, the anticoagulant.
Yes, blood.
That I would like to. And that too after taking the consent of his treating physician.
And how many days before, madam, and after how many days you start this thing?
At least 5 to 6 days prior to the surgery. If a patient stops day before, it's not going to work. 3 to 4 days minimum.
I think yes. Any other medication, that systemic medication, I think that blood thinners are the most common medication which we face, and that we need to stop. So I think Dr. Satyen is here.
Yeah, Satyen is here. You can ask him.
Hi, hello, Dr. Satyen. So like again coming to the basic question of this trap versus tube. So that if you decide to do suppose retrap or you want to do the tube. So in what factors or what grounds you will decide that in this patient I will go for the retrap or this is better for the this AGV.
Thank you, Sifali and Dr. Rajul, both of you. And regarding, I just wanted to put some controversies here. As a primary tube in primary open angle glaucoma, yes, I do. Only in those where the African patients and also for those in the UAE patients, we try to do that because most of the time I'm 100% sure that the trap doesn't work in these eyes. So I do that. That is one thing which I would like to say because when I did almost like 70 traps in a week at Nigeria, I was sure that it is going to fail every patient. So those eyes definitely they need a primary tube, whether it is an Ahmad glaucoma valve or RD is a next question. So in those eyes, definitely the primary tube is more indicated. But in Indian eyes, certainly I don't try the primary tubes. I usually go for the primary traps because it is just a 10-minute procedure you can comfortably do under topical anesthesia. And the success rate is definitely much, much better in our eyes. And coming to the retrap or tube, when the first surgery goes without any complications and it works for at least a couple of years, then I go for possibly a retrap, but having trained in RD and AGV, maybe sometimes it can be equivocal sometimes, depending upon the conjunctival hyperemia or the scar tissue formations. Otherwise, I have said that either one of these is going to be my choice.
So I think that health of the conjunctiva is very, very important factor.
Absolutely.
So we should evaluate beforehand only how is the conjunctiva, whether you are able to move the conjunctiva with the cotton tip applicator with the bud, and then see if it is freely mobile. Then again it is the surgeon's choice whether to do the retrap or the tube. So I think next question to Dr. Vinita, do you use mitomycin C in your all the glaucoma patients, or do you choose a few patients? Like in which cases do you choose mitomycin C?
Thank you, Dr. Shefali and Rajul, for inviting me. Basically, I choose the patient. I don't use mitomycin C left and right each and every patient. Definitely secondary glaucoma patients, high risk patients, very advanced glaucoma patients, I will try to use mitomycin, though the doses definitely can decide according to the case, because we all know as a glaucoma surgeon that we need to individualize every eye and every case. It is not one particular dictum that I do this or I don't do this. We have to definitely take into many considerations before saying anything, but not for all. It's twice I do for MMC, not for every patient because of the risk of hypotony.
Yes, I agree with Dr. Vinita that we need to customize the patients, but definitely the secondary glaucomas, these are the like high myop, aphakic patients, and these patients I think we should use mitomycin C. So now Dr. Rajul has few case presentations and where which will be more interactive and I think more interesting for the general ophthalmologist. So Dr. Rajul, please go ahead.
Thanks. So Shefali, before I go to the slides, Arvind could not join. So I'll ask Satyan and Vanita.
Dr. Satyan, your video is off.
The Satyan's, I think, is traveling. Keep his video off. Satyan and Vanita, their input on what they think that future surgeries will be available or would be good in near future from Indian perspective. Satyan, you go ahead and then Vanita will talk.
Yeah. As of now, not sure whether they're going to introduce the second gen immediately or already there. We have to purchase. But the only issue is definitely like what Arvind was talking about, the early glaucomas and single drug therapies may be a choice, but I'm still not very convinced of going in for that because in Indian context, the financials are going to be one of the crucial things. Regarding the other things like cycloG6, some of the studies shows that when the IOP is too high, you can just do the cycloG6 to begin with and reduce the intraocular pressures, and then go ahead doing your Trebuchet or other procedures of whatever is required. So these are the two things which I can think of. The deep sclerectomies, of course, has been there for many, many years now. I'm not sure how effective. I think some of the people's surgeon's hand, it may be working, but I haven't had a good experience on those. In fact, I haven't tried much of the iStent as well. Some of them have started doing, though the company has a lot of pressure, but still I'm not really too convinced about for the pricing. Probably one or two we need to implant, but still at this moment, I am still not very convinced to go ahead with that. Probably Dr. Vinita has already started, and few of the surgeons who have started can share their views, but financials, I'm still not very convinced. That's the only thing.
Dr. Vanita, your take?
Yeah, thanks. See, I will put it this way. We all have, look after glaucomas which exist in a spectrum. They're not all advanced, they're not all mild, they're mild, moderate, severe, whatever. So where it is severe glaucoma, very advanced glaucoma, I think we have no choice but to do a proper filtration surgery. I don't think anyone would disagree on that. But you also have a lot, at least, we all do a lot of cataracts in glaucoma patients and leave them on medications. Now, in those kind of patients, I now have so much more choice to offer to them. I do remix quite regularly now. I now have a fair amount of experience with iStent, and yes, financials are an issue, but it's completely reimbursable by insurance, completely. Not a single patient so far has had to dig into his or her own pocket to pay for the iStent. And I can tell you that 80% have, what we discussed prior to surgery. Most of them, by the way, obviously they recommend, pressures of 21 to 24 in 1 to 2 drops, nothing like that in the Indian scenario. Most of my patients are either on 4 drops or 5 drops, the kind of patients I have done iStent in, and very intolerant to medication. For the majority, not only have I controlled their pressure, but I've also reduced their anti-glaucoma medication quite dramatically. I was doing Kahoot dual blade, procuring it from abroad, at my own cost. But DGCI has not approved it so far. I don't think there's an application either. So I'm doing bang quite often now. If patients are having to pay out of their own pocket, then I don't even think about iStent. I think about the bent ab interno needle goniectomy procedure. And of course, in angle closure, my first choice now is ECP. And the best results are in angle closure. I also do it in open angle, mild to moderates, and I also do it, of course, in refractory glaucomas. But if I were to rank how ECP works, I would say the angle closures do the best. So far, I have found 60 to 65%, actually, I'm able to take them off all medications.
Okay.
Few where we have reduced them dramatically, and very, very few who have actually failed, for whom I have gone on to do a trabeculectomy. Yeah.
Right. Thanks, Vanita. So
Can I make one small comment, Rajul?
Sure.
So I have been doing this minimally invasive surgery called the high frequency deep sclerotomy by the Earthly machine. And we have had excellent results with them. We even published an international paper on it. but I think it works only in the early and the moderate cases. I would not want to go for an MIGS in a advanced case because we know that we are getting only that much. But the advantage is if you use it early on, instead of using medications, you leave the conjunctiva naive. So if the patient really needs another surgery, you have absolutely nice and clean conjunctiva for the future. The patient doesn't use medications. So compliance is not an issue and toxicity due to the medications is also not an issue.
So I think whatever the literature says, and most of the people would feel that in early glaucoma, these surgeries have some potential. In our situation where we see moderate advanced glaucoma, I think we still have to stick to the traditional surgical techniques of tubes or traps.
See, I'll give you an example. Just today,
Vanita, can I'll give you a chance.
Move on. Yes, okay.
Yeah, I'll give you a chance, definitely. But we'll start the cases because we are running short of the time. So these are all the real case scenarios. And because we are running short, we'll have only few cases. And this is a 69-year-old male physician, cardiologist, strong family history of POIG. His pressures were 16-18. And this is from the records. We had seen much later. And he was on the prostaglandin beta blocker and IOP was ranging 11 to 16. And this is how his field over a period of years. You can see VFI deteriorating by more than 3%, so 1 decibel, and left eye 1.5 decibel. And he was given only medication. The 10 days too I don't have, but in the right eye, this was only 2 decibel. Once it shows 1 and one time 2. So he was told that very high risk of the wipeout, and he was very hesitant for the surgery. So how you would have handled this patient? So we saw here, and we operated both eye for the trabeculectomy, and he's doing quite good. But how early you would have operated these kind of patients, considering the slope, especially in the left eye, which is downhill from the beginning? And how would you counsel the patient? Mayuri Ben?
No. First, the target pressure is not been achieved. That could be one of the reasons. Compliance could be the another issue.
So he was given alpha 2 agonist, which he was allergic.
If he cannot use multiple medications straight away to go for the surgery, early surgery, I would consider.
So he was explained that there is a risk of wipeout. And that's why he was being doctor. So how would you counsel? I basically want that how we can counsel the patient about the risk of wipeout versus the benefit of surgery.
The wipeout is explained if more than 2 quadrants are the foveal fixation is gone. Then only I will counsel for the wipeout. This small defect in the center will not lead to wipeout. Secondly, I will convince that doctor that I am experienced enough. We know the technology, we know the science, and I also use mannitol preoperatively in such patients. Then releasable suture will help me in getting the tight chamber. So all the way, I will try to convince that patient that only 1% or maybe even less chance is getting wiped out.
So I think in an experienced hand like glaucoma specialist, the risk of wipeout is quite less. But we should ideally do size 5 macular program to really assess the wipeout. And after that also the risk. After that also, if the pressures are not well controlled or patient is progressing, then he or she required surgery. And the benefit of risk versus benefit is still in patient's favor. Unless more or 2 or 3 quadrant is 0. So on size 5. Dr. Harsh, do anything you want to add anything?
Yeah, no, I just wanted to consider that I think you are quite right. Though we know that there is no element of wipeout, most of the time it doesn't occur. But one has to tell clearly to the patient, especially a doctor, that yes, we may actually lose vision to some extent. And but the good thing is that you are doing both the eyes. So you can tell him that, okay, bhai, we are doing one eye first because you are seeing that in front of your eyes, everything is going down. So let us do one eye. If it is safe, then we'll do the other eye. So we actually, it is all about talk. But yes, we have to explain that there are chances of going down.
But, and you also have to explain that.
Rajul, can I add one thing? It is because it is for
Sure,
general ophthalmologists. So I think it is a general concept that wipeout means a total blindness, whatever the vision. So that is not the fact. With wipeout in the glaucoma, it means maybe loss of 1 or 2 lines. That is something which is that in this type of advanced glaucoma patient may have this type of 1 or 2, that loss of 1 or 2, but it is very rare what you said. So that I think need to be explained and again to the general ophthalmologist, because most of the time we have seen advanced patient, they are not operated, and when they are coming, they are having 1 or 2 meters. So I think that you should give very clear message, wipeout, even if there is a 1 or 2 loss of 1 or 2 lines, patient, and mostly this loss is mostly for 2 to 3 months, and then usually patient starts regaining. So it is not that complete wipeout is extremely rare.
So I think
please make, Rajul, please make tell the general person to make a consent in the language of the patient. And
yes,
if you feel that the patient is fussy or the relatives are fussy, the sister make a video. You are explaining everything, telling them that yes, vision may go down. Are you ready? Have you understood everything? That is a must, because nobody saves us if things go wrong.
Yes,
okay.
It's a very important point. Yes.
So let's move to the next. Okay, he's done. Okay, so this was open angle maximum medical treatment or pressure going up to 26. We already have discussed this. Wipeout. So I am just keeping this case. 56-year-old operated with mitomycin 10 days ago and had come with for second opinion decrease in vision after surgery. And this was vision was 636, RP was only 2, peripheral iridocorneal touch, mid dilated pupil, and this is the B scan. So what would you proceed with?
No leakage. Siddle's negative.
No leak on the Siddle's negative, no leak. George, you want to proceed step by step and finish up this?
You are mute. Dr. George, you are mute. You have to unmute.
No, sorry, yeah, Dr. Raj, sorry. How many days post-op is that? I just missed that part of it. 10 days post-op. Yeah. So the USG picture actually shows clear fluid. It doesn't look like a, first of all, it doesn't look like a suprachoroidal hemorrhage. It's not an it doesn't look like hemorrhage in those CDs.
No.
That is the first thing. Second thing, no harm. Was the patient on atropine eye drops? We could try, yeah. Was the patient on atropine?
Patient was on home atropine.
Yeah.
Homide.
Yeah, and since the pressures are low, it's 10 days post-operatively. One option is to try atropine eye drops 3 times a day for probably 24 hours. And if still not forming, I feel we might have to explore this wound and see, even with the Siedel's negative, there can be overfiltration due to a inadequate flap thickness, inadequate sutures in place. It has been referred to you from out, right?
Patient gave a second opinion, yes.
Second opinion. So I would probably wait 24 to 48 hours on atropine eye drops 3 times a day, and then probably explore the wound for the reason for overfiltration. But early aqueous misdirection is something we have to keep in mind.
So would you give oral steroids? Would you try oral steroids?
I don't think there is. I don't think there is a role for oral steroids in this patient. I don't know what the other panelists would say, but I don't think there is a role.
It works beautifully sometimes, George. It really works beautifully. Oral steroids with atropine really works wonders many times. With a lot of
in view of the kissing choroidals,
I would think
we don't have much time. Yeah, Mayuri, please.
Aggressive treatment. I will ask my retina guy to drainage.
So
Kissing choroidal is not.
I think, yeah, kissing choroidals is relative emergency if AC is not flat. If there is a lenticular corneal touch, I think we have to immediately intervene. Kissing choroidals, as George was saying, we can wait for 24 to 48 hours. We don't send patient to retina specialist. I think we drain ourselves, and I'm doing it for a long time.
I've seen Raghu's video.
Dr. Raju, but what is the reason for the choroidals here? Is it overfiltration?
No, there was no overfiltration. The bleb was in fact flat. So I know, and there was not much inflammation when we saw the patient. The bleb was congested. So what happened immediate post-operatively, I'm not sure, because patient came after 10 days, but he was not on the high dose of topical steroid. He was given prednisolone only 4 times a day, acetate eye drop. And I'm not sure that also that because pressure was low, the general ophthalmologist decided to give low steroid, and it worsened the inflammation. But the bleb was not over filtering, and we just had to. I waited for 48 hours. Though I don't believe that the systemic steroid.
There's a possibility of a cyclopathic cleft.
No, yes, Satyan, please go ahead.
I think I'm just coming in the same line as Dr. Vinita. So, many times there is a small inadvertent cyclodialysis cleft, which is very hard for us to really see that. So that is very often. The surgeon will definitely know when you have done the trabeculectomy, when you are doing the punching, how posterior punching that we have done, and how much of a iodectomy that you have done, posterior iodectomy. So this will definitely give the surgeon a good idea. And what you have said is true. And what you said is absolutely true. When you have seen kissing choroidals, there is no point, as far as I'm concerned, I really don't go for any other management. Definitely there is a leak somewhere. We got to identify the leak. But even if you identify the leak and you close it, the kissing choroidal somehow it doesn't go. You have to drain the kissing choroidals. Then of course the other part of it also has to be taken care without any doubts.
Agreed. So the 48 hours basically I waited because patient didn't have any blood investigation, especially ECG, and my anesthetist wanted. So I gave systemic steroid, but we had to intervene. And that's what I was saying, George Butran, that I opened the wound to see, but there was no leak. No overfiltration also. There was no conjunctival leak that I knew beforehand only. So we drained, and it's a few years now, and there was no hypotony. But yes, the cleft is possibility, especially when the initial incision, if they have gone too deep, the full thickness, then or while the punching. But this patient was only choroidal effusion. Now the possibility is the inflammation or initially overfiltration, and because of the low steroid, mild inflammation, conjunctival inflammation, it didn't subsequently stop overfiltering. That's possible, but subsequently patient pressures are always in mid teens, and it's now 2 years after I drained. But yeah, in certain patients we have to drain. And I think if the flat antechamber lenticular corneal touch, we don't have choice. We have to immediately intervene. And as Satyan was saying, that kissing choroidal also most of the time we require drainage, and we have to do relative emergency. Anyone want to add anything?
What was like pre-operative status? Like what was the pre-op pressure disc like? Sometime the patient get trabeculectomy even with the NCT of 22.
No, patient had definite glaucoma. His pressures were in, I don't remember exactly, but it was 31, 32 on medical therapy. So the indication for surgery was not wrong.
Okay.
But I think if you share, Rajul,
yeah.
No, it's okay. Basically,
no, please go ahead.
Just for general ophthalmologists, that after TRAB or after glaucoma surgery, if you see the shallow ACs, it is not overfiltering. I think we should step up the steroids. That is because most of the time they reduce the steroids. But I think treatment is to step up the steroids, give strong cycloplegics. I think that should be done first, And if this type of corridors, like there are indications of doing the drainage surgery, then only we should touch the eye.
So,
I think Rajul, your voice is gone. Your net is not working.
You're not at the same place?
We are in different rooms. Rajul?
He's freezed.
Frozen. He's
Yes.
frozen.
So,
In front of wife, he can't speak.
yeah. So I think any other discussion or on this thing, if you want to have, so maybe.
Shifali, just
Yes,
I
yes,
wanted
please,
to
Dr.
add to
Sathya,
what,
yes.
just wanted to add what Dr. Vidita was saying regarding the PGs. It is many of the times it is our feeling that we shouldn't be using that, but we should not go with our own, feelings. We have to understand what is the scientific data that we have. Is that stopping the prostaglandins that we have really achieved something? Only when you have a severe hyperemia, it is okay to probably stop it. But otherwise, it was in the beginning of all our things that we were not sure about how things were. Now we all understood, and it has been there for a long, long time that we really need not stop the PGs. So we have to just move on with what is the scientific data available. And of course, all of us know once you have the PCR, definitely the chances of having a CME is quite high. But otherwise, I think we have to just move on with what is the current evidence that we have.
Yeah, I agree.
That is one thing we need.
Yes.
And Shefali,
We all have
sometimes
many times
people
it is our inner feel that okay, we should not do that, we should do this. But it is better we go with our scientific data.
Not only that, Shefali, sometimes they are already using every medication, and even with this thing, you can actually use prostaglandin analog because only very, very few people will actually land up with CME. And
Actually, we don't stop prostaglandin.
No, I'm saying
Yes.
even post this thing, if there is a problem,
Yes,
you can
that is
still
yes.
give, because very few people will end up with CME, and the moment you remove this thing, the CME will go with the other parameters. So,
and just wanted to add one more thing. If you really notice, the timolol has more evidence of CME than the PGs as such. So it is quite funny to understand that timolol has more evidence of CME than the PGs.
Okay.
Well, at least what we see, at least I have seen many of the PG and causing directly, and when we stop it, it reverts. So I have not seen the timolol as of now.
We have seen quite a good number of timolol with the CMEs.
Anybody else?
It's how you really look for, because we don't even think of whether the timolol will cause CME or not.
Could it be the preservative other than a molecule?
Dr. Satyan, only thing is if this patient is diabetic, then I think that I will consider. So that I think that should be, because a lot of patients are diabetic and they tend to develop CME, especially a post cataract surgery. Even if it is unevenful, I have seen a lot of patients that develop CME.
So can we
in which patients?
Are we done? Shivali?
Yes.
8:30 was the time. Are we done?
Yes, Rajul, yes.
So, we have few more cases, but we'll just stop our discussion here because we are running, we overshoot the time. I would like to thank all the panelists, eminent glaucoma specialists across India, and our speaker, Dr. George Puthran. Of course, Arvind could not join, and the MOS to allow us to do this webinar under the aegis of MOS. Thanks everyone for spending their time on Saturday evening. And before I close, I'll request Dr. Jignesh, our president, to say goodbye to us. Jignesh, are you there?
Raju, thanks to Entod for providing us
Entod, yes. And Entod they would like to run a small video after that. Yeah, Jignesh, please.
Yes, thanks Rajul and Shifali. You're doing a wonderful job. The different topics on glaucoma that you have taken and the panel discussion, I think is definitely going to give a lot of pricey points and what we say, For the general ophthalmologists, it would be very, very useful. These are pearls of wisdom from the who's who in glaucoma, the national and the international faculty who have joined. Thanks a lot for doing on the MOS platform once again. And tomorrow, I think we are again having a session at 7 o'clock. So we welcome you all for that too. And thanks a lot. A big thank you for having it under the MOS platform. Thank you, everybody.
Thank you, MOS, for the opportunity. Thank you so much.
Thank you for having us.
Thank you so much.
Tumor is on angle closure glaucoma and secondary glaucoma.
So, Antod
Yeah.
people wants to play video.
Ashwin, if you want to
We
play
have
the
a gallery
video.
view shot first of all
Yes,
the this thing
yes.
as for posterity hours. And then the Antod video, they usually have to play a minute video before we sign off.
Ashwin, please.
Thank you.
MOS is
Dr.
also
Shefali. I might have to leave.
Madam, एक minute, एक अपने screenshot. They have to take the
screenshot લઈએ છે madam
Just
મયુરી
for a
madam
minute.
જાઓ નહીં આવી
Yes.
રીતે તમે સ્ટાર ફેકલ્ટી છો somebody is taking a screenshot. Ashwin,
I have.
Taken, doctor, taken.
there it is.
Taken?
Yes,
Sorry,
all are
we
smiling.
video.
I have. I'll
Video?
send it to you, Shefali.
Bye,
Yes.
take care.
Yes, I will put it in
Enjoy
the
your
group.
weekend, everybody.
Dr. Harsh is not there. Harsh sir has left, I think. Dr. Satya's video is off.
Usually, I think
Are
they
you,
take,
Antod people are going to show or yes, madam, Rita madam.
No, I was just saying bye to everybody because I guess the Antod doesn't want to show their video or they're delayed and I have guests over.
Yeah,
So-
please, ma'am.
Thank you, madam.
Tomorrow we'll
Bye,
show.
thank you.
Thank you, madam, for your time.
Ashwin, you want to show the
Thank
video?
you so much for having
Tomorrow
me on
we'll
the
show.
panel.
Okay, chalo.
Okay, bye-bye.
Bye.
Chalo, bye,
take
bye,
care.
bye, bye.
Everybody.
Thanks, Vanita.
Bye, everyone.
For your time.
Pleasure.
Yeah.
Can you
Good
please
night,
post
doctor.
your program for tomorrow also somewhere so that we can see?
Yeah, GSI. We will post tomorrow morning. GSI.
Yeah, great. Thank you.
Done.
Thank you, Dr. George.
Thanks,
Dr.
George.
Vanita,
Most welcome.
Vanita, Dr.
Thank you,
Jenny.
Vanita.
Thank you, Dr. Shefali.
Bye, good night. So thanks,
Thanks,
wonderful.
thanks, Thanks, Dr. Rajesh.
Bye, bye. Out
Thank you, sir.
Thank you. Thank you.
See you tomorrow
Everyone.
again.
Rita madam, bye-bye,
Yes,
good night.
yes, definitely.